Our patient travels to us from Trinidad and Tobago, and he's got back pain and going into both legs. He's had it for years, and he has basically a herniated disc at 3-4 and L45 along with a spondylolisthesis. So this is a good surgery for those of you with spondylolisthesis that you wonder, do I need to have a fusion done? The answer is no. His spondylolisthesis is what we call grade 1. It's up to 25% slippage. Shot. Get the wires out, please. Luis, we have a long day, so it's not a great day to do teaching, but if you want to, we will. Now, the spondylolisthesis is happening at L45. Shot. Shot. I'm first docking my needle right on the facet, and then I have to go around the facet. Shot. Which I'm doing. And shot. Shot. Is he reliable? AP? So we're about to enter the foramen. I want to make sure on both AP view and lateral view, and that lateral view is what we have currently, but I need to check with the AP view to make sure I'm where I need to be. So the AP view shows we're in a great position. We already got the AP. So the first step of this surgery is to gain access to the herniated disc. And Jordan, show the viewers where the herniation is at L45. We're going to show you with the white arrow. Can you see the white arrow, Arias?
Yes.
All right, show them where the tear will be. The tear will be right where the arrow is. So that's what I'm aiming for. That's where the herniation originates, is that tear. All right, shot. And if you're going to be a surgeon someday in the future, you want to skive just under the facet. Are you okay? Are you having any pain? The reason the patient's awake for the first part of the surgery is to make sure I'm not too close to a nerve root, because the nerves actually leave the spine right where, just above where we're operating. Show the audience where the nerves are. Is he reliable, Dr. Berndes? All right, well, I feel pretty good where we are. So show them where the nerve is. Just do a little circle right there. That's where the nerve comes out, just underneath the pedicle. Show them where the pedicle is. That's the pedicle. It's a bone. So the nerve comes out just under the pedicle. And if you divide the neuroforamen, the hole where the nerve comes out, into two parts, an upper part and a lower part, show them the upper part where the nerve is. Show them the lower part where the herniation is. That's where you want to be with your needle, in the lower half. Arias, that's for you. Remember that. All right, AP. That's one of the secrets of this technique and staying out of trouble. Perfect. That's perfect positioning of the needle. On the AP view, show them where the nerve is. Show them where the nerve is, Jordan. So, Arias, stay on the X-ray view. Can you see the X-ray, Arias?
Yes.
Show them where the nerve travels. Okay, you see the pedicle? Show them the pedicle. No, that's the transverse process. The pedicle's there. Show them the bottom of the pedicle, right there. That's where the nerve goes. It travels from medial to lateral, right there. So the needle is below the nerve. Okay, back to let's get a lateral shot when you get a chance. We're ready to enter this disc. Yep. So that's our first access point, is left L45. Stay where you are. I'm going to make my incision. This is a 7mm incision. The reason it's 7mm is we want to make our incision as small as possible, but not compromise the ability to do the surgery. So it's really dictated by the size of the tube that I'm doing the surgery through, which is a 7mm tube. Because the outer diameter of the tube shot is 7mm, is that it? Yes, sir. Because the outer diameter of the tube is 7mm shot, that means that the incision only has to be 7 millimeters. Now as you go further up the spine to the L2, 3, and 3, 4 discs, you want to be a little more medial. Medial means closer to the midline in your starting point. Shot? If you're too lateral, you can have problems with the kidneys. That's nice. So I'm just sweeping around the facet joint. Shot? I can feel the herniation right there. So the herniation is in the foramen right there. Okay. Shot? So we're inside the next disc, which is the 3-4. Everybody agree? Can you show us the sacrum? Just so we know we're at the right levels. Is he awake, Berndes? Are you awake? All right, that's perfect. And you can actually stay right there while I do the next one. All right, Arias, can you show the audience how does a herniated disc actually cause back pain? Can you run that video, please?
Sure.
What?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear.
Arias, can you hear me? You're supposed to run inside.
Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Welcome back. And we've just played for you an animation showing why a herniated disc is painful. And the simple answer is inflammation happening in the wall of the disc, in the back wall, where the herniation comes out. All right, everything is going as planned. We are now accessing shot L45 disc through the right side because this is a bilateral procedure. Our patient has pain in his legs on both sides, numbness and tingling and weakness on both sides. So when you have a patient with leg symptoms on both sides and they have a herniated disc on both sides, narrowing and pinching the nerve on both sides, you have to treat both sides. Otherwise, they're going to still have symptoms on the side you didn't treat. That's for lumbar. In cervical, we can treat both sides with one incision. All right. He probably doesn't need a lot of sedation, you know? Yeah. Yeah. All right. So far, we've lost 2 drops of blood. Any questions from our audience? Arias?
No questions.
Wonderful. So right now, we're accessing the last disc that we're going to be treating in this particular patient, and that is shot the L3-4, and I'm looking shot for the facet. Shot AP. And you notice how I stop the tip of the needle before I go into the neuroforamen. That's because before I go in the foramen, I want to know where I am. Am I That's really good. Am I too far forward, anterior? Am I too far backwards? In this case, it's in just the right spot. You can see the other needles in perfect position. So I'm entering this L3-4 disc right where it's herniated. I can feel the herniation. Is he okay? Shot? All right. Shot? That was a really big tear. Give me an AP. That needle went through the tear so easily, and you can actually feel the resistance. This shouldn't be there. Okay? I'm not sure why it's there. You can actually feel the resistance of the tear. This should not have, should be clean. Where have you been for the last surgeries we've done? All right. Is he awake?
Well, he's gonna write it. My friend, can you open your eyes? Perfect. Can you open your eyes for me? Can you open? Okay. We're gonna ask you
Just
some
lay
questions,
still.
okay? Lay still. We're gonna open your eyes. We're gonna ask you a few questions, Doctor.
In a moment, I'm going to run a video for you all to watch that shows what the Duke laser disc repair actually does. But before we do that, I want to basically talk to you a little bit about the #1 cause of back pain for people in the world. It's a problem with the disc. And the reason why it's important that we talk about it is that 99% of doctors don't know about it. So if you go to another doctor somewhere else, they're not going to make the right diagnosis what's causing your back pain because they don't know the disc is roughly, if I had to guess based on my experience all these years, I would say in the lower back it's 85% of the pain in the lower back, 85% of the cause. So 85% of the general population with chronic back pain, the back pain comes from a disc injury. And that's what the Duke laser disc repair fixes, is disc injuries. Specifically, it's coming from a tear in the back of the disc with some herniated nuclear material sitting in that tear causing inflammation, as you saw in the video. Lay still.
Okay, can you open your eyes for me? Can you open your eyes?
All right.
Dr. Duke has some questions for you, okay?
Just lay still. You're doing great. Everything is going well. Are you comfortable?
He said yes.
All right. Everything is perfect. We're going to put you to sleep in a moment, but I just need your participation for just a few more minutes. So a discogram, folks, is a most important test in the world for confirming or rejecting that the disc is the source of the back pain. And there's no other test that gives you more accurate information. Unfortunately, it's an invasive test. Requires needles be stuck into your disc. And we don't like to do that test just willy-nilly off the bat for somebody with back pain. We first want to do a good exam and get an MRI scan, confirm that there are indeed disc problems right where the patient's having pain. So this patient has had pain for how long? And I'm getting that answer in a moment. But long story short, on exam, when I asked him, where is your back pain? He pointed to this square right here, this area. He basically pointed to the L3-4 and the L45 disc.
How are you doing, my friend? Can you open your eyes for me? Yeah, good. Perfect. Okay, his eyes are open. Okay.
Still waiting for an answer from you guys over there. We know that 50% of his pain is his back, and 50% of his pain is in the legs. And it's both legs. 50%. Okay? So he's a 50% back pain, 50% leg symptoms, and the back pain is coming from the tear, the leg pain is coming from the nerve root.
4+ years. 4 years.
He's had really bad pain for 4+ years. Okay? And a lot of our patients have had pain for 10 years, 20 years, 30 years. Nobody has offered them the proper treatment to get rid of it. Are you comfy?
He said yes.
All right. How bad is that on a scale of 1 to 10? You could see him arch his back. How bad is that on a scale of 1 to 10? Show 10. Is that where you get your back pain? Show them the tear.
Yes.
All right, we found one of the bad discs. Put that in. Jordan, show the audience. Arias, go to the x-ray. And Jordan is going to show you the tear causing his back pain. It's in a posterior annulus. That's the back of the disc. Posterior means back, anterior means front, lateral means sides. Show them the anterior disc. You guys see the tear there? Show them. See the arrow, Arias, moving?
Yes.
Is it streaming?
Yes.
All right, that is an anterior tear. It's in the front of the disc. It never causes pain, but the posterior tear does. All right, very good. So one test, one done, and that was the L3-4 was a 10/10, and it was concordant, meaning it's his typical back pain. Are you better now?
I said yes.
All right. How bad is that? How high did it go?
What number? Huh? You said 6.
All right, yeah, it's 6 because I couldn't get pressure. It was leaking out through huge tears. You can see the tears. So that was at worst a 6/10. Is that where you get your back pain?
You said yes.
Concordant. All right, at this point you get to go to sleep. When you wake up, we'll be done with your surgery, okay? So now that I've successfully navigated the needle into the herniated disc, right in the foramen, on the side that he's having leg symptoms, I've done the discogram. I can now put the patient to sleep. He doesn't need to be awake for the rest of the surgery. So my anesthesiologist will do that. He's going to put our patient to sleep. We use Propofol sedation. Propofol is the safest, best drug to use for sedation in my experience for this type of procedure. All right, put the guide wire in now through the needle. I'm removing the needle. And we've already made our 7mm incision. So what I'm going to do is I'm going to slide this dilator down the guide wire because I know that the needle has passed through a safe territory, okay? Remember, my job is to go from this world here where we have our tools into the area where the herniation is causing his symptoms. Shot. You can see the tip of the dilator. Jordan, show them. Uh-huh. And you can see the herniation. Show them the two herniations, one left, one right. You guys see that? That little dark curve? That is the dye we injected outlining the two herniations, one on the left side, one on the right. Arias, when I ask a question, I need your answer if you can see what we're talking about.
Yes. We can see it.
Thank you. All right. So now I'm entering the herniation and the tear, and I'm pushing the herniation that's in the tear, I'm pushing it back into the disc where I'll retrieve it. It's a big tear. Literally, that went in so easy. Take it out. Shot. Perfect. So now we've got our dilator. We're going to now put we're going to now do the whole surgery through this tube. You see this, Arias?
Yes.
Now the outer diameter is 7mm, and that's why our skin incision is only 7mm. By the way, Duke Spine Institute broadcasts all of our surgeries live, and Henry is out on vacation. Arias is covering and doing a stand-up job. And then I know Jose will be covering later today. Shot? We are now entering the L45 tear. I've positioned the tube at the end of the tube, right where I want it. It's inside the tear, at the base of the tear, right at the innermost part of the tear. So Arias, we're going to switch over to the endoscope in a few seconds here. I'll tell you when. But can you see the back here, Arias, pretty well?
Yes.
Let's turn the lights off and turn the other lights on. I want to show you guys what I'm talking about. Okay? Can you see this, Arias?
Yes.
All right, so if this is the annulus fibrosis, it's thick. It's about 1 centimeter thick, maybe 1.5 centimeters. And when you get a tear in the annulus, there's the inner part of the tear and there's the outer part of the tear, right? And then you have the jelly which is pushing out through the tear, stuck in there. That's your herniation. There's two parts to the herniation. There's the part that's stuck in the annular tear, called the interposed herniation, IPH. And then there's the part of the herniation that's way out here, outside the disc. Okay? And that's really the extruded fragment, or extruded herniation. The part of the herniation that typically causes leg symptoms is this part outside. And that's what all surgeons focus on. The part of the herniation that causes back pain is this part, the interposed herniation. And that's the part that surgeons ignore, doctors ignore. But Duke Spine Institute discovered 15 years ago that this is the actual cause of their back pain. And the same thing in the neck pain, thoracic pain. That's what we're targeting, is that tear and the herniation inside the tear, as well as the part outside. We can get it all. Okay, here we go down the scope. Arias, are you able to switch to the scope view?
Yes.
All right, can you see inside the scope now?
Yes.
Excellent. So we are literally at the base of the tear, and I'm going to start pulling out those pieces of herniation I told you about that we pushed back into the disc. Remember I said that as we put the dilator in? There's a piece of herniation right there. Okay? So I grabbed it because it's loose, and it wasn't loose before. It's loose because I shoved it from outside the tear or inside the tear itself, the interposed, back into the disc. So what you're seeing right there is the bottom of the tear. You see those fibers? We're going to work our way from the bottom of the tear, the inside part of the tear, to the outside. Let's go ahead and show our audience, Arias, a video animation showing how the Duke laser disc repair works. Can you do?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Okay, welcome back. And we are just started doing the laser on the annular tear. This is the most important part of the surgery for eliminating back pain from the disc. Remember, there are about 30 causes of back pain in the lower back, and the most common cause by far are the herniated discs, or bulging discs, as some people know them. They're all truly herniations. The names given to them are just different names for the same thing. So when you hear extruded disc, ruptured disc, protruded disc, herniated disc, bulging disc, disrupted disc, they're all essentially the same problem. There's really no difference. Degenerated disc is when the disc starts to collapse over time and darken, lose water, and the end plates of the bones start to take on a more irregular shape, and they can even thicken. We call it sclerosis. So these are all really just a continuum of the same process. It all is a herniated disc. That's what we call it, okay? So I tell people don't get so caught up in the semantics. It's really a tear with a herniation. That's what we're dealing with. Now the blue thing is the laser fiber, and the blue is actually plastic covering the glass of the laser fiber. Laser energy is a form of electromagnetic energy. Electromagnetic energy is invisible for the most part when it's laser. Laser energy is not visible to the human eye. However, what we see every day with our eyes, visible light we call it, is also a form of electromagnetic radiation. But it's a different wavelength and frequency, and it's something that over time our eyes have adapted to perceiving and interpreting with our brains. But we cannot see laser energy. Sometimes you'll see a little red dot at the end. That's just a targeting beam, and that's a visible light targeting beam. It's built in by the manufacturer of the laser so that the surgeon can actually see where it's pointing. Now, a lot of people ask me, Dr. Jukmajian, is the laser safe? The answer is yes, it is safe, as long as it's used properly by a skilled surgeon who knows how to use it. Obviously, the first time I used the laser, when I didn't know what I was doing, if I didn't know what I was doing, it would not be safe, right? But if you're taught how to use the laser by an experienced surgeon, which I was, then you can actually use the laser very safely. So some of the things that I do to maintain safety is I use cold irrigation, refrigerated. And the reason why it's cold is the laser generates heat at the tip. But when you have cold irrigation, you use convection to remove that heat and dissipate the heat. So to basically get rid of the heat. Also, we use irrigation to sweep away the debris. That's very important. You see how things are moving around, right? They look like they're shaking and moving. What's actually happening is that's the irrigation moving through the tube, taking with it the fragments of disc that I'm releasing with the laser. Some people want to know how do lasers work. Well, in this application of lasers in spine surgery with Duke laser disc repair, they work by delivering a high energy to what is basically proteins, right? So macromolecules, biological macromolecules, organic molecules we call them. So we're delivering this laser energy to these organic molecules, and the organic molecules absorb the energy, and the energy is so powerful that it causes them to break apart at their covalent bonds that hold the atoms together. So we're basically disrupting covalent bonds, which are electrons being shared between atoms that hold these molecules together. Any questions from our audience so far?
None at the moment.
Excellent. Another question I get is this laser FDA approved? The answer is yes. The lasers we use at Duke Spine are FDA approved. The laser fiber is FDA approved. And the use of the laser and the laser fiber in the spine is FDA approved. The same laser can be used in other procedures, like treating kidney stones. Lasers have been known to blast kidney stones and break them up into little pieces. So also lasers are used to treat tumors and vaporize tumor cells to rid the body of tumors. Lasers are being used more and more in medicine. because they're very safe and effective. There is no tool I can use right here in this endoscope that works as well as the laser. There's no metal tool. There's no surgical tool other than the laser. Think about this. You see the walls there at the bottom? The metal walls? Those are about 5.5 millimeters wide. They look much wider to you and me because the endoscope magnifies things. But see the glass fiber down there at the tip of the laser? That's 0.5 millimeter, 0.5 millimeter wide. So that gives you an idea of just how small of a space this is. A lot of patients, people ask me, well, if you're taking the disc out with the laser, isn't what's going to be in there when you're done? The answer is we're not taking the disc out. We're just taking the herniation out. And we're debriding the annular tear. Okay? So it looks like a big area that we're treating, but it's actually tiny. It's very precise. And it's this one precise area that causes all of that horrible back pain. And again, that was discovered at Duke Spine Institute years ago. We've published this surgery. As a matter of fact, Arias is one of the original authors of this publication. He's one of the original scientists that did the research and the work to bring this technology to the world publicly. All right, we're done with this disc. Okay? And you can actually, there's a little bit of fat there in the foramen, and then the nerve root. Can you guys see that white right there at 12 o'clock? The white band at 12 o'clock? That is the nerve root, the exiting nerve root. And that's the traversing root right there. You guys see that white? That's the traversing nerve root. So it's heading down to the next level. So we're done at this L4-5. The nerves are decompressed. The annular tear has been debrided. Come on, man, you cannot let that flip around.
Irrigation, switch needle.
Arias, any questions?
No questions.
Why don't you go ahead and run? Are you streaming?
Yes.
Have you verified your stream on a laptop?
Yes.
All right. Why don't you go ahead and run the video showing how the Duke laser disc repair works if you haven't done that already. Keep broadcasting. And if you get a question, let me know. And you're streaming on YouTube, Facebook, Twitter, and LinkedIn, correct?
That's right.
All right, good. There you go. All right, tube is out of L4-5 on the left. We're going to bring our fluoroscope back in. You know, it would be kind of cool, Luis, in the future, maybe trying a case like this, putting in the 4 dilators and the 4 tubes.
We have another dilator you want.
No, but what I'm saying is,
Like
rather than bring the fluoro in every single time,
yeah, put it all. Have all of them in each. Oh, so let's do that.
not this case. Shot?
That's a nice idea. Seriously, 75%.
I'm just thinking, brainstorming.
I think that's a great idea.
All right, let's try it. We can even try it on the other side if you have another tube. But then again, we have a lot of cases today, so I don't know how that plays in. Shot? Okay, at this point, we're heading for the L3-4 disc. And want to make sure that these guys don't come out. How's he doing? Huh? Do you want me to wait? Shot? All right, so we're going to enter the L3-4 next. Shot?
We had one question from
Shot?
Amir.
From Amir.
Yes.
All right, Amir, we're happy to take your question.
Doctor, what if you accidentally pinch a nerve during the surgery?
What if I accidentally pinch a nerve during the surgery? Well, it does happen. I mean, in any surgery on the spine, nerves can be pinched. Let's say a nerve gets pinched, it should make a full recovery. So it's not like you're doing permanent damage when you pinch a nerve. If you cut the nerve in half, then you're going to have permanent damage. But if you're just pinching it, you should be fine. Let's pull it back a little. The patient might have symptoms. They may have weakness. Some of our patients have really badly pinched nerves to begin with, and when we're unpinching them, once the nerve is unpinched, they can actually have symptoms like pain in the leg. We call that nerve root regeneration pain. But pinching the nerve myself during surgery is possible, but that's why we have the patient awake. So we have a lot of countermeasures in place. We're just going to go to that. We're going to do that later.
You don't want to...
No, when I go to that side, I want to do the 2.
Oh, you don't want to do it?
I don't want to do 3.
Gotcha, gotcha. Okay, gotcha. Oh, yeah, pull it. Pull it. Thank you. All right.
So pinching a nerve usually is fully recoverable. The nerve will grow back because it's a peripheral nerve. If it was the spinal cord, it wouldn't grow back. That's different. Spinal cord nerves can't grow back, but peripheral nerves can. So you want to avoid it, obviously, but sometimes the space is so narrow you don't have a choice but to pinch the nerve a little bit.
Stop on, please. Endo, this guy. Thank you.
So I'm sure I've done it in the past, and in the end, patients always do fine as long as you don't cut the nerve. All right. So now we're inside the L3-4 disc, the second one we're going to fix. We're on the left side. We're going to move to the right side when we're done here, and we're going to put 2 tubes in. It's going to require a little bit bigger incision in the skin.
We had another question.
Sure.
What are the causes of a herniated disc? From El Shaddai.
Wonderful. So happy that we're getting so much audience participation today. What are the causes of a herniated disc? So the number one and only cause of a herniated disc is trauma. Trauma. And the trauma occurs to the annulus, which is the wall. You cannot have a herniated disc without trauma. It's impossible. But most doctors don't know that, but it's true. Herniated disc requires trauma first. The trauma is to the annulus, the wall of the disc, where you get a tear. And I'm going to have Arias rerun the video animation showing you how it works. So the step 1 is trauma causes an annular tear in the posterior annulus. Step 2 is squeezing the disc like you normally would when you're bending or twisting, and that causes the jelly to squeeze through the tear that's already there from the trauma. So step 1, trauma, annular tear. Step 2, normal daily activities. Normal bending, twisting, lifting will cause the jelly to squeeze out through the tear. So it's a 2-step process, and then after that, herniation of the jelly, the nuclear material, out through the tear. You can have more herniations over time. Every time you bend and twist or lift, carry something, See the tear right there? You guys see the tear, okay? That was beautiful. You can actually see the annular fibers on the right and left. And now I'm going to clean the tear. The blue stuff is the nuclear material inside the tear, the nucleus pulposus. Okay, so there's the right side of the tear, and there's the left side of the tear, and the tear is white because the annulus fibrosus is white. That's its natural color. It doesn't stain blue with the blue dye. The nuclear material does stain blue when it's degenerated. So when you see a blue stuff, that is the herniation inside the tear that's degenerated. It's already being broken up and broken down by your body, attacking it. The inflammatory system attacking it, trying to get rid of it. That's a piece of herniation that just went by us. I'm trying to get rid of it, but it doesn't want to leave.
We had a few more questions.
Happy to take the questions.
From Fendi Peeler from YouTube. He says, how long after this procedure would the patient be able to resume daily activities?
How long after the procedure will the patient be able to resume daily activities? The next day. You can go back to normal activities the next day. There's no hospital, there's no downtime. It's 1 hour recovery. After 1 hour, you're walking, doing normal things. The only restriction the first day is no driving a car because you've had anesthesia. Not because of the surgery, but because of the anesthesia. So you're not allowed to drive a car or operate machinery the first day. No boat, no car, no helicopter. You know, the list goes on. But the next day you can go back to normal activities.
We had one more question from San Juan Estate, and sort of a question that I suppose I could answer as well. But he asks, or they ask, apologies, does patient age play a big factor in the complexity of a procedure like this and the recovery time?
Great question from San Juan Estates. Does patient's age play a factor in the procedure difficulty or recovery? The answer is no, not at all. We've operated on 15-year-olds who have herniated discs that are painful, all the way up to 95-year-olds. We don't discriminate based on age. Age has no factor. What matters is other things, like, of course, cardiovascular status. So is the heart good, the lungs good? And number two, medications that the patient's taking before their surgery. Are you taking some drugs that, you know, could be affecting the anesthesia, like powerful painkillers or benzodiazepines, or even nowadays THC, marijuana, right? Huh? Alcohol use. So if you use alcohol, is bad. These other drugs are bad. But if you come clean without any drugs and you're healthy with your heart, then you're going to have a perfect surgery. Nothing wrong.
We also conducted several studies recently and examined age as a factor in all of the patients, and age was not confounding in the results.
Wow, I didn't know that. I mean, that's great to hear, Aris. Thank you. I didn't realize that the age, they looked at stratification based on age, and there was no difference in the outcome significantly. So that means doesn't matter what age you are, you're going to have a good result. Equal result to the younger people. Is that right?
That's right.
So just for those of you who don't know, Arias is performing data analysis on our patients who have had surgeries and looking at outcome measures that are important outcome measures. And we're using a statistician. Arias, maybe you can tell us more about the statistician, their training.
Yeah, sure. We have a 3-step process of data mining, statistical analysis of the data, and then summative writing analysis of the data for publication. And as of now, we have 3 papers that are pending for publication or about to be pending for publication. Our statistician is trained in RStudio, and for the past few tests, we've been running some complex statistical analyses such as a t-test or a Wilcoxon rank test in order to standardize our data. So, yeah.
Thank you. So for those of you who don't know much about statistics like me, statistical analysis of data is important because you can have a difference in results, or you can have an outcome that looks good, but unless it's statistically significant, and what that means is that if you were to do the same test over and over again, would you get the same result, or was it just by chance that you got your result? And so when you have a significant result, it means a p-value, which is a measure that is less than 0.05. It means that 95% of the time, if you do that same test, you're going to get the same result. So if the Duke laser disc repair shows good results and the p-value shows as less than 0.05, it means that if we were to redo the test with a different group of patients and do the same test, the same treatment, you're going to get the same result 95% of the time. Thanks. So statistics are very important in assessing whether or not the treatment works, and whether or not you can say it works, and whether it's repeatable results. And so we've been working with a statistician to analyze our results for the laser surgeries and other treatments we do, and we found that our results are very strong results, meaning that if we were to do the surgery on more and more people, we get the same results we got now, which is basically a 95% elimination of the back pain and leg symptoms. So that's as strong as it gets. There's really no other surgery in the world that has that for back pain and leg pain. All right. So great questions we're getting from our viewers today. But the recovery is very quick. It's usually 1 hour. And that again was a result we found in our study of the results of our patients. 1 hour recovery, and there was no difference in the ages, the different ages of the patients. They all had the same result, which was a good result. Aris, you want to expound on that a little bit, or you think we've covered it?
Yeah, I mean, all of the data that we've mined so far and analyzed have all been statistically significant, meaning that there was major improvement post-operatively. There are several data measures that are pretty standard that we look at, one of them being a major one, VAS scores, which are indicative of a patient's pain level preoperatively and postoperatively. And yeah, for each study that we've done, whether it's a fusion or a Duke laser disc repair, we've all found very significant pain improvement and pain relief from pre-op to post-op. And it stays that way for weeks, months, even years to come in several of our long-term studies as well. So the surgery lasts, and it's extremely effective.
Yeah, thank you. So it's effective and it's durable. All right, I'm just finishing up this disc. I'll be done in another minute or two. And this is the left L3-4. Left L3-4. We've already done the left L45. A lot of scar tissue here we're seeing right here. This is from chronic inflammation, which is, remember we talked about the inflammation that happens inside the annular tear. This is it. It's all white. This white stuff is scar tissue. So the annulus tears, and then the herniation comes, and the herniation creates inflammation in the outer annulus first, which then spreads to the inner part of the annular tear. Great questions. Any more questions at this time?
Yes, we've got one more question from Ed K on YouTube.
Hi, Ed.
Ed asks, is it possible to treat L4-L5 left foraminal herniation and L5-S1 central and right foraminal herniation on the same treatment session?
Yes, it is. So one of our viewers was asking, is it possible to treat these multiple herniations in the same treatment session? The answer is yes. Yes, because they're all lumbar, it's very easy to do. If it was different parts of your spine, cervical, lumbar, then we can't do it in the same session. But because it's all lumbar, we can. Very good question. Just about done. This is the last of the tear and herniation right here. See how it turns a golden color with the laser? That is calcium. So that's what we call it, starting to calcify. This disc herniation starting to calcify, and specifically dystrophic calcification, spelled D-Y-S-T-R-O-P-H-I-C. Dystrophic calcification happens in the body, the human body, in response to damaged tissue and inflammation, chronic inflammation. All right, you can see the epidural space right there. You can see a little bit of fat, some veins. You see the veins opening and closing with blood? Those are literally veins, tiny, tiny veins. Remember, this glass is 0.5 millimeter. So that vein right there I'm touching is probably 0.3 or 0.2 millimeter. And then you can see the fat cells right there, the golden fat cells. And each one of those sparkles is another fat cell. So you can actually see the cells. You guys see them? Right there, the
Yes.
individual cells. So we want to leave those veins alone. There's no reason to mess with them. I went back in just one more time into the disc. So when I was there for you, I was in the foramen, the neuroforamen. And I can clearly see outside the foramen now. I can see everything, and the herniation is completely gone. Okay, very nice, very nice. Aries, can I get a very nice?
No.
All right. All right, so we're done here. Coming out with the laser. At this point, I'm gonna just give a little bit of antiseptic. Now, we've never had an infection in a Duke laser disc repair. We've done over 1,500 in the last 16 years. It's about 100 a year. The last couple of years, we've been doing more. So there were some years where we did less than 100, but on average, it's 100 a year for the last 16 years. And we've never had an infection. Have you ever heard of spine surgery without an infection? No. And the reason is it's so minimally invasive. Plus, there's no bleeding, virtually no bleeding. There's no metal or hardware put in. So it's a very safe procedure that has virtually no complications surgically.
We have another question from E_class on YouTube.
All right.
E-class asks, how much does a procedure like this cost for C5, C6, C7 repair?
So a 2-level cervical Duke laser disc repair, we would need to meet with you and do an MRI review to be able to price it out. But Richard would be the person to talk to on pricing. I don't have the pricing. I don't do the pricing. I just do the surgery. The pricing is determined by the surgery center of Vieira, where we do our surgeries. So we'd be happy to give you a pricing once you do an MRI review. Arias, will you type into the dialog box mri.dukespine.com? You can get a free MRI review, and no cost to you. You just have to fill out a form and upload your images and the report. And then once we've done that and we confirm what you need done, you're able to get your pricing right away. All right. So now we're on the right side of the patient. How's the blood pressure? Are you happy with it, or? Yeah. All right. So, great. No, thank you. Cuffs working, good, all that jazz. All that jazz. Let's see. All right, at this point, we're making our way down to the number 4-5 disc on the right. And let me just look at that x-ray. I want to redirect my, yeah, that's better. You really want to be careful. You want to let the guide wire guide you. You don't want to go forcing it one way or another. Shot. So that's what I'm trying to do, is just slip along the guide wire. I could feel this now entering the tear. All right, so that's, hold on. That's feeling good. Now we'll take the guide wire out. You don't want to pinch the guide wire. If you pinch it, shot, you could end up fracturing it. And you don't want that. A fractured guide wire would be a bad thing. That's why Luis and my team, we inspect them all the time and get new ones when we need to. Shot. Looking good. You want to keep an eye on the tip of the dilator. Show them the tip of the dilator. Okay, right there. And show them the tip of the tube. Yeah, right there. Perfect. So you can see the oval shape of the tube. You never want that tube and the dilator going too far past the front of the spine, because then you could end up in the pelvis or the abdomen. That's good.
We have a question from Raymond on YouTube.
Sure. What I was saying, though, before you give me the question, Aris, is you got to keep an eye on the front of the dilator, make sure it doesn't go forward into the pelvis. Because what happens is you get a little bit of disc material between the tube and the dilator, and it can actually, I don't want the guide wire in there. Why are we doing that? Oh, you want to do the double tube? But let me see. I don't know if we have enough room. We're going to have to make a bigger incision. Let's stop. Let's leave it for now. Let me think about it a little more. Yeah, just put that. Okay, we are now inside the L45 disc on the opposite side, the right side, and we're going to do the Duke laser disc repair here as well. All right, we'll take the question, Aris.
Raymond from YouTube asks, Doctor, how do you handle Spondy L4, L5?
How do I handle spondylolisthesis at L45? And this is Raymond?
Yes.
Hi, Raymond. Do you see the x-ray? I hope you can see that x-ray, because there is a spondy at L45 in this patient. And you're seeing how we're handling it. We don't fuse it. We don't do anything but the Duke laser disc repair. It's all you need to do. Most other spine surgeons will tell you it needs a fusion, but it's not true. It does not need a fusion. That looks perfect. Thank you. So this patient has a spondy at L45, grade 1, which is the majority of spondies are grade 1. Probably about 90% of them are grade 1. And we're not doing anything with the spondy. The reason we're not doing anything with the spondylolisthesis is because it's not causing any problems for this patient. Spondylolisthesis really never causes problems. Unfortunately, it's just something that surgeons see and then they tell you need to fuse it, but you don't. The spondylolisthesis can be treated effectively by this surgery. The reason is that the spondylolisthesis itself doesn't cause any symptoms. What causes symptoms is the annular tear at the spondylo level and pinched nerves at the spondy level. And we're fixing the pinched nerves by doing a decompression. Most surgeons are going to tell you you need a fusion at a spondy level because they're going to go and do a laminectomy to unpinch the nerve. And when they do the laminectomy, it's going to destabilize the spine even more and cause more back pain. But remember, laminectomy doesn't fix back pain. It only treats leg symptoms. So the back pain associated at the disc where you have a spondylolisthesis will never get better unless you treat the tear like we are with the laser, the Duke laser disc repair procedure, or you fuse that level. So other surgeons, they don't know how to do the laser surgery, this particular surgery. Therefore, they can't get rid of the patient's back pain unless they do a fusion. So if all you have is a fusion to treat your patient with, then they're going to recommend a fusion, because that's the only way to fix the pain at this level is a fusion if you don't know how to do endoscopic surgery. And that's why these surgeons are recommending fusions, because they don't know how to do the endoscopic surgery. So basically what I'm saying to you is, because the surgeons are not capable of doing more advanced spine surgery like this, they're going to offer you the older type surgery that they were trained to do years ago. Okay? I don't know how more politically correct I can put it, but I think you can understand what I'm saying.
We have another question from Ronald Shepard on YouTube.
All right, Mr. Shepard, happy to answer another question.
Ronald asks, sorry if this was asked before, can you do this DLDR at a disc where fusion was performed by the surgeon, or was performed, but the surgeon left the disc in there, or would that probably not be causing back pain?
Hello, Mr. Shepard. Wonderful question. I love your question. And it has been asked before. I think it was asked by you, but that's okay. It's a rare question, and it's an important question. So the question is, surgeon does a fusion on the lumbar spine, but leaves a lot of herniated disc still there. And if the symptoms are coming from that fused disc, can you go in there and do the laser surgery at the disc? And the answer is usually yes, we can. And does it need to be done? Yes, it does, if the fused level disc is still symptomatic, because the surgeon didn't take it out. Just to be clear, what I'm talking about is when you do a fusion in the lumbar spine, there's many ways to do a fusion. And the problem is there's many ways to do a fusion. There's really one best way to do a fusion, and that's the way that I do fusions, because I could do any fusion any way I want. I'm capable technically of doing it. But I choose to do it my way, which is the transforaminal lumbar interbody fusion with Smith-Peterson osteotomies and a complete removal of the disc and replacement with a cage. So I do that surgery, and I've published it. If you go to the literature, you'll see the exact surgery I'm talking about under my name in PubMed. The reason I do that surgery is because other types of fusion surgery typically don't work as well, and patients still have pain, or they don't fuse properly. But the transforaminal lumbar fusion with combined anterior and posterior interbody arthrodesis and posterolateral fusion with interbody cage and Smith-Peterson osteotomy surgery that I'm talking about, that works really, really well. But there are surgeons who don't take the whole disc out, and they leave it there. And when you do that, that disc can still be a source of pain. So the question is, would the Duke laser disc repair work in that case? The answer is yes, it should. The only problem is, can I get to the disc? And the reason I say that is sometimes the fusion mass over the transverse process in the back is so big because the surgeon put so much bone back there that it would block access to the disc. Now that said, I've actually done the Duke laser disc repair on an L4-5 already fused segment posteriorly where the surgeon left the disc, and the patient did very well. We got rid of his pain. And what was interesting is that I tested the disc with a discogram, even though there was a fusion at that level, and guess what? It was still painful intraoperatively. So I knew we were doing the right thing by actually treating it. So the simple answer is yes, we can, but the more complicated answer is, does it really need to be done? And will I be able to gain access to the disc transforaminally, because the facets are now fused together along with the transverse process posteriorly, I assume. So to completely answer your question, I need to do an MRI review. and I probably want a CAT scan so I can look at the fusion mass and make sure I can get past it. Okay?
We have 2 more questions on YouTube.
All right. Sorry for the long-winded answer, but it's not a simple answer.
First one is from Ronald Shepard on YouTube again. Ronald asks, also, is there a way to fix
Good job,
back pain
Oscar.
caused by a laminectomy?
So the question was from Ronald Shepard, is it possible that back pain is caused by a laminectomy?
No. The question is there a way to fix back pain caused by a laminectomy?
Is there a way to fix back pain caused by a laminectomy? The answer is yes, 100%. Laminectomies don't cause back pain. Laminectomies make back pain worse. If a laminectomy is done and the patient still has back pain, it's because the disc is hurting or the facets are hurting. So we can still treat your disc and facets. Understand something. What is the number 1 cause of back pain? The disc, herniated disc. What's the number 2 cause? Facet joints, arthritis in the facet joints. Which of those does a laminectomy fix? Neither. Laminectomy doesn't fix back pain. Laminectomy is supposed to unpinch the nerve roots and fix leg symptoms. Okay? So can we fix back pain after a laminectomy is done? Yes. But I need to do an MRI review first.
We have another question from E-Class on YouTube.
Hello, E-Class. Is that like a Mercedes E-Class? I'm just curious.
E-Class asks, are there other spine surgeons in the United States that are doing this kind of surgery? Also, if not, why aren't any surgeons capable of doing these procedures? And do you believe in the future they will?
Great questions, E-Class. So the first is, are there other spine surgeons doing the Duke laser disc repair? The answer is, I don't know of any, and I don't think there are because I haven't trained any directly, okay? So it's an interesting answer, but the answer is very important. I could not do endoscopic spine surgery without being trained to do endoscopic spine surgery by an experienced endoscopic spine surgeon, which I was trained 16 years ago and ongoing. I mean, so for someone to do this surgery, I would have had to have trained them. I haven't trained anybody. So I don't think there's anyone doing this, but you know, I can't tell you because I don't know for sure. That said, I could tell you nobody should be doing this surgery because I haven't trained them directly. The training would take about a year, maybe 2 years. They would have to work with me every day for 2 years, and I haven't done that. So are there people out there that say they do my surgery? Absolutely. Are they lying? Absolutely. Would I go to them if I were you? Absolutely not. It's dangerous to go to surgeons who are not properly trained to do surgery. Okay, second question. Do you see this as being the future of spine surgery? 100%. This will be the future of spine surgery. Why? Because consumers demand it. You, the patients, want it. It's far better than anything else out there, far better. And it's less expensive than other types of surgery, like fusions and artificial discs. And it's safer, because we don't have complications. And it's more effective. It results in better outcomes than fusions and artificial discs and laminectomy and discectomy. And there's no need for postoperative narcotics, opioids, from the surgery. So the problem with open back surgery is that everybody is prescribed Percocet or Dilaudid or oxycodone or OxyContin or hydrocodone. All these powerful painkillers are needed after spine surgery because the surgery is so invasive and damaging to your body. The painkillers are needed after surgery because of the damage from the surgery. Think about it. The patient didn't need those painkillers before their back surgery, but they need it afterwards. Well, why? Because the surgery caused damage. Okay? Our patients don't take painkillers, they take Tylenol. And that means we didn't do much damage to them, okay? Now, obviously it's still surgery and I'm sticking a metal pipe in their back. But when these patients come back to me the next day, I ask them, does your muscles hurt? And they say no. So you have no pain here? No. Right where I stuck that pipe, they don't have any pain. So it's an incredible surgery, and also that it doesn't require dangerous opioid medications after surgery. So the small, less invasive, no opioids, better results with relief of pain, and a faster recovery to where the patients are basically on their feet the same day.
We have two.
And less expensive. So how could it not be the future? Most importantly, it has better results. After all, why do people get surgery? For their results. They want better results. And the results of fusion are typically 50-50 that they're going to have improvement in their pain. The results with Duke laser disc repair are almost 100%. I mean, I don't even know a single patient who didn't get better. So the average pain relief is 95%.
We
and
have two.
It's durable. Sorry.
Yeah. We have 2 comments on Facebook
Uh-huh.
and then several questions on YouTube. So I'll just read the comments and then I'll give you the question. Janet Parker on Facebook says, it is very sad other spine doctors don't do what is best for their patients. They do what is best for their wallet.
Yeah, I agree, Janet Parker. It is sad. Just so you all know, I took my surgery and presented it to the neurosurgeons of the world at meetings, Miami international meetings where neurosurgeons from around the world come. And it was very well received, meaning the surgeons loved it. They thought it was amazing. But how many of them called me and said, hey, can I come and learn how to do this? None. Why? Because the culture in the United States and the world is a culture of fusing. And the reason for that is fusing an artificial disc. And the reason for that is the companies that make the implants, these multi-billion-dollar companies, hold the tube? Yep. They're standing to lose billions and billions of dollars for this technology because it doesn't require screws. So they basically don't want this technology getting out there. And they're doing everything they can to prevent it. So that's why we decided years ago to do these broadcasts, because I think people need to know the truth. I was one of those fusion surgeons for many years. I did 1,000 spinal fusions on people's backs. And I don't regret any of them because for the last 15 years I've offered patients the opportunity to do the laser surgery instead. And many of them wanted the laser surgery but didn't get it done because they couldn't afford it. So there are definitely financial challenges. Some insurances don't cover it. As a result, people have to pay out of pocket. So it is difficult in that sense. All right. And the other comments?
It was another comment from Janet, but I'll just go ahead and read the question and we can get back to the comment. Imran Rashid on YouTube asks, I have problems in my neck, stiff neck problem C5, C6. What is the cost for disc repairs? Send your WhatsApp for further questions. Thanks.
Yeah, I'm sorry. I don't have WhatsApp, first of all. I don't use that app. But as far as costs go, again, I don't have the costs. The costs are with our surgery center, and they're always dependent on how many discs and how many levels, how difficult it is to treat. Yeah. Yeah, I need it because I'm getting a lot of, okay, you cannot do that, okay? It's just simple. You cannot do that. Just don't make the same mistake again. You've done it before. I need you to remember. All right, Arias, what other questions?
We had another question from Imran Rashid on YouTube.
Have you switched the irrigation yet? Go ahead.
Imran asks, my age is 54 years and doctor said to avoid. I have to do physiotherapy and some said to try injection.
So Imran, to answer your question, if your pain is coming from a herniated disc, which is the most likely cause, physiotherapy and injections will never fix it, ever. And you'll still have the pain afterwards. So you have to ask yourself, is that what you want for yourself? Do you want to go through treatments that don't work? We have physiotherapy in the United States, but it doesn't work for herniated disc, ever. So you can do it, but it's not going to help you. All right. Grabber? Is that him or you?
That's me. I'm just adjusting his,
Be nice, just let me know next time, okay?
just checking his pressure.
I don't see any more herniation here. Looks good.
Lights on, please.
All right. Scope off. Great questions from our audience today. I really appreciate it. I enjoy answering the questions. You may not get the answer you want, but it's the best answer I can give you. And so far, we're done with 3 discs, 3 areas. We have 1 more to go. Again, our patient is visiting us from the Trinidad and Tobago Islands, and he came here for the Duke laser disc repair. We have a lot of international travelers that come because they don't have this technology available in their country. All right. So I'm removing this tube. And one thing I will say about this patient's spine is that it's very posterior. We talk about where is the spine relative to the skin on the back. And some patients' spines are very far forward. Other patients' spines are sort of neutral. And then others are far back. And the ones that are far back for me are my favorite because they're honestly technically the easiest. The patients with spines that are very far forward are hard to get to because the facet joints almost block access to the disc. He has a lot of inflammation back there. You could see some of the bleeding. That bleeding is just veins that are bleeding, and it's coming from the back of the disc where there's been inflammation going on for years. Inflammation is interesting. It's your body's system attacking what it believes to be a foreign invader. And that foreign invader happens to be the nucleus pulposus. It's not really foreign, it's part of your body, but it's not recognized as part of your body because it's been locked away in the middle of the disc for your whole life. And now it comes out during the herniation. So it's the first time your body sees it. So your body treats it like it's something bad, and it attacks it. And it's that attacking of the herniation at the outer annulus that creates the inflammation and the pain as a result. We all know inflammation causes pain, especially if you have pain fibers, nerve fibers that bring conscious pain, which everybody does in the back of their disc. Shot? All right, we're entering the last tear. And once we're done here, we'll be done with the surgery. Big tear, very big tear. Any more questions, Arias?
None at the moment.
Aris, would you mind rerunning the video animation showing why do annular tears cause back pain, please? Shot.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Welcome back. We've just shown you once again our YouTube video animation explaining how a herniated disc itself will cause back pain. And this patient definitely had back pain from his herniated disc. We verified that with the discogram. The L45 disc, I was not able to get it to hold the die to get a pressure reading, to get it pressurized properly for the discogram, because the tear in his disc is so big that the die just leaked out. And therefore I don't have a reliable L45 discogram because I wasn't able to get some pressure in the disc. It's the pressurization of the disc that actually elicits the pain response when they have a painful disc. So I essentially had zero pressure. The die just fully leaked out. But he did get a score of 6/10. So we did get some useful information, and it was concordant pain, meaning that's his typical pain. All right, we're almost done. I got 5 minutes left on this surgery. We're at the L3-4 on the right side, and it's going very well. Not having any problems. The patient is very stable. He's sleeping. We use Propofol and MAC. MAC stands for Monitored Anesthetic Care. And basically, what's being monitored is his breathing, his oxygenation, ventilation, as well as the heart, blood pressure, the vitals are all being monitored, neurological status. So it's a lot harder from an anesthesiologist standpoint to do these kinds of surgeries because the patient's not intubated. It's much easier to manage an intubated patient, right, than it is to manage a patient who's not intubated. All right, any questions from the audience?
No current questions.
Okay, very good. Arias, when you're done, will you make sure that we get this file saved?
Sure.
What is our next surgery?
A lumbar, left approach at 3-4, bilateral approach at 4-5, and then he has a DLDR thoracic at T8, 9, 10, and 11 on the left side.
All right. I remember. Yep. Why is the rate on this different?
Jordan, what's going on with, is it the same or? Jordan, the rate? Same cost.
Jordan. Something you want to tell me, Jordan? Uh-huh. Two minutes. Arias, any more questions? We're going to be...
None at the moment.
I'm sorry?
None at the moment.
All right. Well, folks, I hope you enjoyed the surgery. It went very well for the patient. I expect him to do well. Come on, man, you got to have your hand ready. That's not how you do it. Don't apologize. Fix it. Laser. You're supposed to hand me the laser before you put the tool down. You're supposed to put the tool down after you hand me the laser. Is that not obvious? Okay. All done. Yeah, I'm looking. Looks good. And then you can sign off if you'd like. Were we on a video?
Nope, just muted.
Oh, why would we be muted? Yeah. We don't mute, Arias. We record everything. We're done. We fixed the L3-4, L45 on both sides with the Duke laser disc repair. And I always put pressure on the muscles for about 4 minutes. You can actually see the incision on this side. You see that, Arias?
Yes.
That's 7 millimeters, tiny. This is endoscopic spine surgery. It's outpatient surgery. The patient will go home, back to his hotel in about an hour, hour and a half, once he's woken up completely. There's no hospital stay, and we've done over 1,500 of these surgeries in the last 16 years without a single infection. The chance of re-herniating is 1%. Okay, you guys see the incision there, Arias?
Yeah, show it to us a little bit more.
Right here? You
Perfect.
actually have to pull it apart to see it. But right there. Very good. Great job, everyone. Thank you, Arias. You can end the stream. And good morning, I'm Dr. Ara Duke-Majan, CEO and founder at the Duke Spine Institute in Florida. I have one of my patients who just had surgery yesterday, and he traveled from New York with his lovely wife, and they are here for the Duke laser disc repair, which he had done yesterday morning, just 24 hours ago. What kind of problems were you having with your neck before the surgery yesterday?
So about, 20 years ago, I had a pool accident. And then in 2009, I had seen a doctor and I had a fusion done. And then after that fusion, which was C5, C6, years went by and I started having problems again with the neck. Severe pain, sharp pain going down into the arm, pains along the back, problems sitting, problems sleeping, constant pain. Went to pain management and tried a list of different type of, chiropractic, physical therapists, and just couldn't get rid of this pain that I had in my neck.
Right.
So I was recommended to see a surgeon in the New York area. I went to him and he recommended a fusion of C6, 7.
Right.
So I researched more and I found you online, and we had a Zoom meeting and you reviewed what my issue was from an MRI, and I was just amazed at what you told me you could do with no long-term effects. I mean, here I am, I had surgery 24 hours ago. You would never know it. Look at me. You're not holding me up, right?
No.
Is that amazing?
This is
Truly
modern
had
technology.
surgery, truly. And I feel so much better.
It looks like
Yeah.
you're turning your neck a lot better.
I am, see that?
No pain.
Without
with that, is it?
hesitation.
Yeah,
So that's
just like
great.
that.
They just took my Band-Aids off. I walked in here, I feel great. I don't have any pain in my shoulder and going down my arm. I can lean back now with no burning sensations in the neck. It's just amazing. And my original fusion, when I heard they wanted to do another one, I was worried because it was so painful. I must have been in bed for a week and a half before I can even move around. And they put a drainage in your neck. It was just very uncomfortable.
Barbaric.
Yeah, it was like crazy. And then I'm like, why isn't everybody coming down here?
They should, because we have figured out the right way to treat herniated, bulging, degenerated discs in the neck, and it's with a laser and endoscopic surgery. And you found
Traumatic injury to the disc can cause annular tears to form.
And good morning, I'm Dr. Ara Duke-Majan, CEO and founder at the Duke Spine Institute in Florida. I have one of my patients who just had surgery yesterday, and he traveled from New York with his lovely wife, and they are here for the Duke laser disc repair, which he had done yesterday morning, just 24 hours ago. What kind of problems were you having with your neck before the surgery yesterday?
So about, 20 years ago, I had a pool accident. And then in 2009, I had seen a doctor and I had a fusion done. And then after that fusion, which was C5, C6, years went by and I started having problems again with the neck. Severe pain, sharp pain going down into the arm, pains along the back, problems sitting, problems sleeping, constant pain. Went to pain management and tried a list of different type of chiropractic, physical therapists, and just couldn't get rid of this pain that I had in my neck.
Right.
So I was recommended to see a surgeon in the New York area. I went to him and he recommended a fusion of C6, 7.
Right.
So I researched more and I found you online, and we had a Zoom meeting and you reviewed what my issue was from an MRI, and I was just amazed at what you told me you could do with no long-term effects. I mean, here I am, I had surgery 24 hours ago. You would never know it. Look at me. You're not holding me up, right?
No.
Is that amazing?
This is
Truly
modern
had
technology.
surgery,
Yeah.
truly. And I feel so much better.
It looks like
Yeah.
you're turning your neck a lot better.
I am, see that?
No pain. with
Without
that, is it?
hesitation.
Yeah,
So that's
just like
great.
that.
They just took my Band-Aids off. I walked in here, I feel great. I don't have any pain in my shoulder and going down my arm. I can lean back now with no burning sensations in the neck. It's just amazing. And my original fusion, when I heard they wanted to do another one, I was worried because it was so painful. I must have been in bed for a week and a half before I can even move around. And they put a drainage in your neck. It was just very uncomfortable.
Barbaric.
Yeah, it was like crazy. And then I'm like, You know, why isn't everybody coming down here?
They should, because we have figured out the right way to treat herniated, bulging, degenerated discs in the neck, and it's with a laser and endoscopic surgery. And you found us, you came, you experienced both, because you had the fusion years ago in 2009, now you had the laser. How would you compare the two in your mind?
Night and day.
Yeah.
I mean, I would never get a fusion again. Never.
Well, now that you've had your surgery, I know you were asking if you can go to the beach today and go in the water, and I said yes. What kind of things are you going to do now that your life is going to be without this pain?
My activity is going to be much better, and enjoyment of life, my family. Don't have to go lay down in the middle of the day when people are over. It's just going to be great. It's a new start.
Absolutely.
So I appreciate it. Thank you very much, Doc.
That's why I'm here.
It's perfect. Great job.
Anything else you want to say to your fans out there?
Just listen, it's the good doc here does an MRI review. He doesn't charge you for it. And you'll get to meet him and you'll get to see, you get his opinion on what you need, and you're gonna end up being very happy. It's a short ride or flight. I'm coming from New York. It's well worth the flight down here.
Yeah, we couldn't tell you were from New York.
Oh, you couldn't tell by the way I talk?
Yeah, of course I can. Well, congratulations.
Thanks so much.
So happy for you guys.
See, I'm up. I feel good.
Good.
Yeah.
That's why we do it. You're welcome. It's Dr. Ari Dugmajian at the Duke Spine Institute here in Florida with one of my patients who had the Duke laser disc repair for a back injury, and it was around 6 to 8 weeks ago. And you're back for a checkup. How are you feeling today?
I feel wonderful. I feel great. I feel fantastic. I mean, this is the man. He's the man.
Well,
and I came in with a lot of pain, I couldn't believe it. And now I'm virtually pain-free. It's unbelievable.
How long did you have your back pain? How did that start?
Oh God, that happened many years ago at work, at least 20 plus years. And I had other surgeries in the past, and they really didn't help. And this last one, it just got so bad that I had to do something. So luckily, through the grace of God, I came here, and
Amen.
yeah, and I'm A1 now.
Awesome. So you had your surgery. You've been doing therapy. Would you say the pain you had in your back before surgery is still there, or is it gone?
Oh, it's gone. It's gone. I have little twinges now, but they're muscular, and that's.
Should be able to hear you.
I'm Dr. Dugmajian. We've just finished a bilateral L3-4, L45 Duke laser disc repair, endoscopic repair of herniated disc. And this patient had herniated discs with annular tears at L3-4 on both sides and L45 on both sides. He also had a slippage of the bones called the Spondylolisthesis, where L4 was slipping forward on L5. He did not want fusion surgery, which had been offered to him in the past. He wanted the Duke laser disc repair. We're able to fix the discs with the laser and the endoscope without needing to do hardware or artificial discs or fusion. It's a more advanced technology. Most spine surgeons don't know how to do the surgery, and this patient traveled from overseas to get here and have it done. So everything went very well. We didn't have any complications. He lost 20 drops of blood, basically, very little. We found a lot of inflammation in those backs of the discs at L3-4, L45, where he's been having his pain. The source of the pain is inflammation, and it's inflammation that is occurring in the back of the disc where the tear is and the herniation is. Most surgeons don't understand the source of pain and how to treat it. Therefore, they won't offer you the right treatment, which is the endoscopic Duke laser disc repair. We had a lot of questions during the surgery. These are very good questions from our audience. I tried my best to answer them during the surgery, but we still have some more questions, and we'll get through those right now. Arias, what's our first question?
So we had one question on YouTube from San Juan Estate. They say, can the patient dance the night away from New Year's comfortably?
All right, wonderful question. Can the patient comfortably dance the night away on New Year's Eve? Well, New Year's Eve is about 2 weeks away, and the answer is absolutely. Now, I don't think he's going to be Saturday Night Live quality dancing like John Travolta was, but definitely there's dancing that's going to happen for this patient.
And then we had a comment on Facebook from Janet Parker, who says all spine doctors should be doing this surgery. If they really want what's best for their patients, they would.
Janet, thank you. I agree. Janet made the comment that all spine surgeons should be offering this opportunity, this surgery for their patients. And just to tell you how I feel about that, I agree. Number one, I wasn't taught the endoscopic surgery in my neurosurgery training in the United States at the University of Florida. Just to give you an idea of who I am, a little bit of background, I graduated valedictorian of my medical school at USC, and every year a group of doctors graduate med school and they go around trying to get a job, a training job as a neurosurgery resident, and it's a 7-year training program. In 1996, when I applied, I was literally the #1 draft pick in the United States. I had the best research, the best grades. I had the highest recommendations. My chairman was Dr. Marty Weiss, and he was the head of the residency review committee, which is basically the seat of power in neurosurgery. He knew all the residency programs. He knew all the chairmans. There were about 110 of them back in 1996. And he was my advisor, and he told me the best training you can get is at University of Florida in Gainesville with Dr. Roten and his team. So I went there and I did my training at UF in Gainesville, left Los Angeles, California, where I grew up, and I really feel like I got the very best training. But I can tell you, nowhere in the United States was endoscopic surgery being taught in the spine. And I didn't understand why at the time. I was doing a lot of fusions, and very well. We had great results with fusions, really great results. But it turns out over the last 20 years, it's become very crystal clear to me that the companies that manufacture and sell metal for the spine are controlling what the surgeons are doing. And I mean that, literally controlling what the surgeons are doing. And there are strong incentives for surgeons to do fusion. Now, one of them is you get paid a lot more money to do a fusion surgery than a laser surgery. I may make $500 on a laser surgery. If I did a fusion, I would make $10,000. So there's strong financial incentives for more invasive fusion surgery. Artificial disc, you might make $5,000 per disc. So the incentive to do metal, whether it's a fusion or artificial disc, is very high. Now, why do doctors recommend laminectomy? Why do they recommend microdiscectomy? The reason is simple. Because they know that's the first of many surgeries you're going to get. And they know they're going to be putting metal in you in the future. So basically, it's just a way to drag out your care and make the patients go from a situation where it's very easy to fix endoscopically their problem, but by doing laminectomy and discectomy, you're removing the natural bones in the back of the spine, you're weakening the spine, and the spine ends up being more painful, more problematic, and the patients end up needing fusions. So basically, they're just setting the patients up for a fusion. And they're making some money on the front end by doing some extra procedures. It's a very corrupt system. Nobody's talking about it. Nobody understands it the way we do at Duke Spine. We're trying to make a change, but I can't do it alone. I don't have the ability to do it myself. So we're bringing this information to the world and the public because you guys, the patients who need surgery, are the ones who stand to benefit the most from less invasive, more effective treatments like Duke laser disc repair. Duke laser disc repair has been peer-reviewed and published multiple times in the medical literature. It's on PubMed. It's in the National Library of Medicine. There's no excuse for surgeons not to know about it. And to be quite honest with you, I see a lot of patients with brain problems, other problems that I could treat, but I don't. Why? Because I'm not the very best at treating those conditions. I send these patients out to better doctors, better, more trained, more qualified. They do this stuff every day. So you're right. Surgeons, spine surgeons, should be doing the surgery for the patient's benefit, and they should be learning how to do it, and they should be switching to it. Yes, it pays a lot less money, you're right, but we don't do medicine for money, we do medicine to make people better. And that's something my father taught me. He said, always do what's best for the patient, and your patients will be happy with you. So I believed him, I followed his footsteps, I'm here, and that's part of my daily philosophy. That's why I went and trained over in Asia. I had to go to Korea, I had to go overseas, I had to learn from German and Korean surgeons how to do this surgery. I didn't learn it in the United States. I didn't learn it in the top neurosurgery training program in the world. This is kind of a side technology that is not popular among spine surgeons for the reasons I've said. Okay, thanks for the comment.
That's it.
All right, hope you enjoyed the surgery. We'll be back shortly in about 30, 40